All right, go ahead, Wendy.
Great. So last month, we presented on the clinical maturity. So that was all about the clinical providers. And this month, we're going to present on the community perspective. And this is, if you'll recall, we had we divided up that RFP, and the clinical, the community portion was given to WSU team. So I'm going to turn it over to Christina, Janessa, and Susan. They're all on your screen if you look for their names, and I'll turn it over to them. They'll be sharing their own slides and going through that presentation. And that should be also on your calendar invite for the board. I will throw a link in the chat for others who are interested.
Hi, are you seeing just the overall presentation, or are you seeing the display slide?
Display. So you're
I hate when it does that. 1 second. Better?
Yes,
you got it.
All right. Been using Zoom for a year. You think I'd figure this out by now? All right. Well, we'll go ahead and get started. I'll just go ahead and get to the project team. So Christina Sanders is the Director of Division of Governmental Studies and Services in WSU Extension. I am Project Manager at DGSS, and we've taken a role in helping do the various community elements. And Brian Anderson is also part of DGSS. And Janessa Graves is with the College of Nursing, and she did the GCM, which she's going to talk about more in depth. And we also had Kevin Harris from the William D. Ruckelshaus Center, who's an expert in healthcare policy, who was helping us on the project. So I wanted to introduce our team and then just dive right into it, because there's a lot. We're going to give a little bit about the methods we use to kind of take the community pulse, or community's pulse, right, in the region, present some of the results from each, and some preliminary recommendations and discussion we're seeing based on what we have captured from the communities. So going ahead, we use a lot of different methods to try to gauge opinions and perceptions on telehealth in the region and preferences for telehealth in the region. This included semi-structured interviews with organizations in the region. The initial list we created had over 300 organizations. We created 4 priority groups based on that. The first priority group was organizations that were involved in healthcare, in some form of healthcare. The second priority groups included city governments, nonprofit organizations, and then there were 2 other priorities over that. We also talked to public utility districts, or tried to reach out to public utility districts. So we talked to a broad range of organizations. There were 3 waves of invitations. That seems low. I feel like we did more than that. There was a lot of back and forth trying to schedule interviews. We conducted the interviews over Zoom, and we had 28 total participants by the time that we were done. As part of the project, we also did a key informant interview with somebody with the district library, and then we did a survey of libraries as well, and they helped us distribute that. We don't focus much in this presentation on the information we garnered from libraries, but we did try to figure out what kind of resources libraries had to potentially help support telehealth in the area. We also did group concept mapping. It's a way to brainstorm approaches for, well, group concept mapping is an online, it almost looks like an online focus groups in a lot of ways, except everything can be done asynchronously for the most part. So you have participants sign on, they do a brainstorming of approaches. We had them focus on providing or accessing telehealth in their community. You sort through all the collected ideas into groups, and we had them, the final step is rating feasibility, impact, and costs. And so from that, you do a statistical analysis of the group ratings of, we did feasibility, we did impact, and we did costs. And you can do a statistical analysis and kind of identify options that are considered high feasibility, high impact. We generate thematic grouping and ideas from this, but we will present, Janessa will present GCM more in depth and kind of the results of that. We also did an end user survey. So there was an online survey of individuals. We did a survey in English and a survey in Spanish. We distributed that through Facebook and other means, although Facebook at times was less successful than we had hoped in getting the reach out for the survey. It was shared via email and social media. And when we were finished, we had 493 English survey respondents and 133 Spanish respondents. So That sample is very limited, but it does give us some insights into telehealth preferences in the region. And then we also did secondary data analysis. We pulled census data, we pulled Washington State broadband data to kind of assess what the region looks like and their readiness for telehealth. So I'm going to go through some of the results and then turn it over to Janessa when we when we get to the GCM analysis. So we did semi-structured interviews. So when the time we were done, we had 4 healthcare related organizations. We had city governments, non-governmental organizations, and 1 public utility district in the final tally. So the interviews we did across the organizations said that telehealth is absolutely needed. They need increased access to medical care, and the people that they are serving need this access to healthcare. So there was agreement that it was a definite need in the region. Some of the things for why it's a need is the distance to services, especially for specialty care. The distance is too far, especially for a lot of populations. There's a lack of specialists in the area. And one thing that they also mentioned was that there's no one approach. There's no one approach that's going to serve everybody. That we need a multitude of strategies given the diversity in the region and the healthcare related issues and the technology related issues. And one government employee, we quoted this because it really solidifies that need, is we deserve a telehealth service. So there seems to be support behind this and agreement that it's necessary. They also noted several challenges in the region to a telehealth strategy, especially a singular telehealth strategy. And one of the big ones that comes across all of the methods is broadband access. Broadband access, which you know, is a big issue in the region. There's a high level of lack of broadband access. They also mentioned the lack of technology. There's a lack of access, but there's also a lack of knowledge. And there's real concern about that because as you acquire this technology, if people are frustrated with it, they're not going to use these services. Knowledge is a big issue. They also, and this comes out in other methods too, but it was really big in the interviews, they emphasized that there's trust concerns. There's concerns over security of the telehealth platforms and whether their information is secure. And there's a high amount of distrust in terms of whether they'll be safe utilizing these services, whether their information is secure. And so that's a big barrier that will have to be overcome. And this came across several different organizations with several different groups that they were servicing, that trust would be a very big issue with any telehealth strategy that was pursued. They also mentioned that outreach and awareness was really important. Not only outreach and awareness that the communities have to know that this is available and how to use it. So there has to be some sort of campaign to let them know it's available, but also many organizations that there has to be awareness among providers, that we need providers to be on board. And some people who are already working in telehealth mentioned that it can be very difficult to get a hold of providers in order to support telehealth strategies. Some of the clear issues that come out from these interviews in terms of whatever strategy is pursued, broadband access, technology, and trust is a big issue. I feel like I'm going really fast. The end user survey. So as I said, we had 493 English survey responses and 133 Spanish responses for a total of 626 percentages of respondents. So the percentage on the left is the English survey. The percentage on the right is the Spanish survey. So about 45% were from Chelan, 25% from Douglas for the English survey, 9% from Okanagan, Grant 15.4%. If they lived outside of these counties, they didn't take the survey unless they indicated that they got services within those counties. So even if you didn't live in those counties, but you routinely received medical assistance there, you could still take the survey. Just looking at this, we didn't use non-probability sampling, so we can't generalize from this in terms of margin of error and confidence intervals, but we can kind of look at the sampling to tell us what it tells us and how comparable it is to the population in terms of age and some other factors. The respondents to the survey tended to be younger, which is not surprising given it's an online survey. They do tend to trend younger. Respondents tended to be more affluent or wealthy, which is also not surprising given an online survey, and that will impact how they respond to some of the questions in the survey. There are some differences between English and Spanish surveys, which are interesting and deserve a further look into, especially as any strategies are pursued on how that would impact the Spanish population and their needs and preferences. So we asked several questions in the survey, and we're only focusing on some of the questions in this presentation today. We asked about their usual source of medical care. And a high amount of the Spanish respondents indicated that hospital or emergency room was their usual source of medical care, which is interesting given that they tended to respond to the survey. They were wealthier than the respondents who responded to the other survey. They tended to get their medical care from the hospital emergency room. For the English survey, 38% stated that they primarily use primary care, followed closely into that by the hospital and emergency room, but it was much more evenly distributed for that group versus the Spanish survey. So perception of current healthcare access, majority of respondents rate current access to be good quality and affordable healthcare. They were positive. They overwhelmingly said they had good quality and access to affordable healthcare, which is again interesting when you consider that many of the Spanish respondents indicated that they were using the emergency room for their treatment or the hospital. Many respondents feel that there are not enough specialists in the area. We asked about specialists and what specialists they would like to see. The two big areas of need that came up across those surveys was behavioral and emotional health and cardiovascular specialists were lacking in the area. Many respondents have a healthcare need that is hard to get care for in their community. So they did indicate there were needs that they had issues getting care for. Perceptions of good access and affordable care. So access to good and affordable care, just kind of want to show this excellent, good. They had they could rank from excellent to very poor, not sure. In terms of both, overwhelmingly said good and affordable care. And for the Spanish survey, it was remarkably overwhelming majority said it was good and affordable care. And again, that is interesting when you consider that a high amount of them are using the emergency room. In the English survey, about 40, a slight majority, 54% said that they had difficulty receiving care. And then in the Spanish survey, 64% said that they didn't have difficulty finding care, which is another interesting finding when you consider the two groups and their responses to other questions. Perceptions of telehealth, most are for expanding telehealth. They think it'll meet the healthcare needs in their community. They think it's a good strategy for meeting the needs in their community. Most participants are familiar with telehealth, which shouldn't be surprising given COVID-19 that they have used telehealth in the past. The most preferred telehealth are video appointments and phone appointments. Overwhelmingly, they prefer either video appointments or phone appointments to receive that care to other strategies. They do have several concerns with telehealth expansion, including internet access and reliability. Privacy, again, that concern of privacy, security, and trust comes up in the survey and concerns over that. Technology access and the quality of care that they will receive in telehealth versus in-person appointments. We did ask them if telehealth options help meet healthcare needs in their community, and just overwhelmingly yes. More so for the Spanish survey, as 91.5% said yes, compared to 73% in the English survey. Familiarity with telehealth, again, most are familiar, which isn't surprising given COVID-19. We did ask how much they had used telehealth both before and after, and unsurprisingly, it went up both prior to COVID and during COVID. It went highest for online and phone appointments. And again, that seems to be the preference too for online or phone appointments. But it went up across the board except for self-service kiosks and mobile health clinics. Willingness to use telehealth services in the future. A high rate indicated they would be willing to use telehealth services in the future. There's limitations to survey questions like these. It's very difficult to determine future behavior based on survey questions, but there was a high amount that indicated that they would be interested across both surveys. A high majority among the Spanish respondents versus the English respondents, but still pretty high overall. We asked them also to rank the telehealth service types that they would be willing to use. And so I did want to show that video again. There is a slight difference between, well, I shouldn't say slight, there is a difference between Spanish respondents and the English survey respondents. For the Spanish survey, the majority said they would rather have phone. Why that is, we can't really speak to. It might be that interpreter services are better via phone. It might be an internet access issue, although they're taking an online survey, so it could be difficult to tell what that is. We did notice that a high amount of Spanish surveys respondents seem to come from similar locations, so it could be indicative that they're using a community service or a library to fill out the survey and get access to that, or a school. But 56% preferred phone. For English survey, a slight, almost half preferred video. Less preferred the other options that we gave them, telehealth, kiosk, and mobile health. I'm going to let Janessa take over and do the group concept mapping to show those results.
Awesome. And I'll just say next slide when I want a next slide, if that's good. You can advance it. Okay. So group concept mapping is really this great method for engaging participants and essentially combining qualitative and quantitative data. So it's really neat. And if anyone has ever sat through a group, a meeting in person where you have ideas on the whiteboard or ideas on pieces of paper around the room, and you're voting with little sticky notes and putting ideas on sticky notes, and then the facilitators grouping them together. I'm sure a lot of people have had that experience. This is very similar to that. So there are 3 steps that I'm going to talk about. There are actually 6 steps in group concept mapping, the methodology, but I'm going to talk about 3 in this presentation: brainstorming, sorting, and rating. And so during the brainstorming session, we're asking participants in a separate survey from the end user survey, but community members and stakeholders, with a prompt. And so the prompt we used here was I think I'll get to it in the next slide, but what ways can we bring telehealth to your community, or what are some effective approaches for bringing telehealth to your community? So this is really sort of positive mindset, not looking at barriers, but like what are some options that might work out for North Central Washington? The next step is the sorting step. And so the sorting step is we take participants, again, they can be the same folks or a different group of folks, and ask them to sort all of those brainstormed ideas into conceptual groups. And so essentially imagine taking all those Post-its and grouping some Post-its here, and maybe they put some over here that are a different type of idea, and that's how sorting works. Rating is completely separate, and that is taking each of those ideas and asking respondents or participants to rate them on various metrics that we've provided. And so we asked our participants to rate each of these brainstormed ideas in terms of impact to their community, feasibility in their community, and potential cost. And we said, if you don't know, just do your best guess, because obviously I don't necessarily know how much it costs to do, telehealth carts in every fire department in Okanagan County, for example, but they can kind of guess vis-a-vis the other brainstormed ideas. So for the brainstorming step here, you can see the number of respondents in the table at the top. So we had 14 respondents individually provide sort of just this brain dump of every possible idea they could think of. And then we also pulled ideas from the key informant interviews. So we went through all of the interviews, and any ideas that bubbled to the surface or came out in those interviews, we threw into the pile as well. And then for the sorting step, we had 16 respondents, and the rating step, we had 16. So these numbers down at the bottom, we initially had 61 statements that participants provided, the 14 participants and the interviews provided. And then we review them, and we kind of go through and see, is this redundant? Make sure there aren't any major errors in spelling or inappropriate content, and then also divvy up some that were potentially multiple ideas embedded within a single statement. And so we went from 61 statements actually to 70. A lot of times you'll go from a lot to a little, but in this case, people would just provide a brain dump of ideas all within a single answer box. And so we had to kind of separate those out. And so we ended up with 70 ideas or brainstormed concepts after the review. Next slide. These are some examples of statements from the brainstorming, and I literally just kind of picked these out of the list, so they're not representative per se, but the prompt that we gave folks was possible approaches to providing or accessing telehealth in North Central Washington communities include ... And they could just put whatever they wanted. So we had things from expanding broadband access to providing transportation to locations with telehealth access, or providing, really out of the box ideas, providing solar powered picnic tables that have free Wi-Fi and a place to plug in a laptop. Or the other example is establish telehealth centers with privacy and booths and rooms in central locations in town. So we had 70 of these sort of types of concepts. So these are examples of those. Next slide. So this here is a point map. And so after the respondents had grouped all of the concepts, so they saw a whole list of these concepts, and they said, group these ideas together and group these, figure out which ideas are similar in your mind and give them each of those piles a label. So every number here on this map, this point map, represents an idea. So it's 1 through 70. And you can see that the proximity to one another indicates similarity of ideas. Does that make sense? So we have, this cluster off to the right, top right, northeast corner. We have sort of the northwest corner cluster, and then we have like the southeast, if you will. Next slide. So next we have the cluster map. So this was what we deemed to be the optimal cluster solution for the project. So it's based on sort of how cohesive are the statements within each of the concepts. And so we could have done a 15 cluster map and there would have been a bunch of little boxes around here, but yeah, we could do 70 clusters and then be 70 ideas and each has their own cluster. But we really wanted to try to nail it down for you all to provide these kind of concise groups of ideas. And so based on the cohesiveness of statements spatially in the point map, and then also the hierarchical cluster analysis within the software that we used, the final solution comprised 6 clusters. And so in this map, there are these ideas of, well, we'll switch this. Can you go to the next slide? So this is the cluster solution with the labels. And the labels were created by, respondents, when I create the cluster, I can see kind of generally what's a possible cluster name, and then I tinkered with them a little bit and fixed some spelling errors. But let's talk about cluster 1 to start. So cluster 1 contains approaches to providing and access telehealth that require some or involve some community infrastructure. So this includes example 2, quote unquote, establish telehealth centers with privacy booths and rooms in central locations in towns, the example I showed you before. This statement had a really low, what we call bridging value, indicating that participants consistently sorted that with other statements around it. And so all of these statements really hung tightly together. So there's 17 statements in this cluster, and they include telehealth kiosks in community locations like supermarkets, doctors' offices, fire stations, and also mobile vans serving as Wi-Fi hubs to communities and public parks. Cluster 2, which is right below that, it makes up, there are 11 statements there, and we call that ensuring access to telehealth technology. And so that includes approaches that evolved bringing broadband, laptops, or hotspots to communities to and allow members to access telehealth. There was some conceptual overlap with cluster 1. So in cluster 2, we had a suggestion to establish internet kiosks, which is unsurprising given the proximity of the cluster. So their clusters are very similar, but they're also different because the first one, community infrastructure, really is engaging community entities to help carry out these interventions. So, they're real community partnership clusters. Cluster 3 had 6 statements in it, and that relates to the technology infrastructure required to implement a telehealth program. So these were such suggestions like create a service or an app to make booking telehealth appointments more easily, or have a app to link healthcare information across different platforms. So real tech oriented. Cluster 4, which is the northeast corner, so think Maine, New York, is characterized by 15 statements that describe different approaches to accessing telehealth that require training or awareness of telehealth within the community. So educating community members about telehealth, that it's easy and reliable and convenient and private, or ways to increase computer literacy. Then the two other clusters on the West Coast here, we have cluster 5 that had 4 statements in it, and they were pretty heterogeneous. That's why there's like this little stack on cluster 5, because they didn't really hang together really tightly. And these were all just very kind of broad statements like create a telehealth system like 911 for triage and intervention to connect relevant resources. Or another example in this cluster would be changing state and federal regulations to be more accepting of telehealth services. So very broad interventions, not restricted to just focusing on a single town or community. And then cluster 6 had 17 statements in it, hung together a lot better. And they were looking at this one, included suggestions for providing access to telehealth that would require or involve engaging the healthcare system. So this would be providing trainers for healthcare providers. So it's kind of the brother to cluster 4, if you will, but it's really focused on the healthcare system. Ensuring access or ensuring local clinic staff are on board with telehealth as an alternative platform would be an example of something that was sitting in cluster 6. So that was a lot. We'll go to the next one though. So this one, here are the results to the rating step. So again, we have 70 little dots on this diagram. The colors of the dots actually correspond to those clusters that I just described. But the x-axis, so the horizontal axis down here, is impact. And so this is how impactful each of those suggestions might have been rated by our cluster. So it's the average impact of each of those ideas. And then on the y-axis is the average feasibility. So how our respondents rated the feasibility of each of the potential intervention or potential approaches. Can you go to the next slide? Does it create a little box? Yes. So this little red box here is called the go zone. And that really is the great way to kind of distinguish what are some potential approaches to providing telehealth in North Central Washington that are both rated as high impact, potentially, and relatively feasible compared to some other ones. So, you know, the ones on the far left corner, that quadrant, are going to be things that are a lot harder to change or might not have an enormous impact either. So we really want to focus on that go zone, that northeast quadrant, and look at different statements within that quadrant. Next slide. So here's just some statements, and this is all of the statements that exist in that quadrant. So I'm just going to maybe pick a couple and cherry pick a couple, but I'm going to let y'all read through these. We only had 1 from cluster 1 and cluster 2, and then 2 from cluster 3. A lot of them were from other clusters. So cluster 4, remember, was educating the community about telehealth. And so these are ideas from cluster 4 that were rated as having a really high impact and a really high feasibility. So these are utilize outreach workers to bring resources to places like orchards or migrant camps, provide community training, educate community members that telehealth is easy and reliable, and just providing that community education. So here, and then the next slide, it has some more. We could switch really quick. So cluster 5 had 1, but then cluster 6 was healthcare system engagement and delivery. So cluster 4 and 6 are really the 2 that were just the meat of them were sitting there in the go zone. And so cluster 6 include things like engaging clinics and providers on overcoming barriers to implementing telehealth services, providing affordable platforms for people to use, and for training local healthcare providers, for example. So that, I know I kind of got excited and started talking fast toward the end. And so we could switch between these slides if y'all want, and, provide, I think this is within your packet to provide, because I think, Susan, correct me if I'm wrong, but I think that's the end of my little slides. Then we move on to secondary data analysis.
There's a hand raised, Penny.
Sure, Penny.
So I have one concern, and that is knowing your data. So earlier you were like, hey, I don't know why they're accessing the ER and why they're saying, if they are saying that they are the more wealthy in this census, why are they accessing the ER? And then do they need a different way to access telehealth because they're saying that they want to use their phone? And I think it's important that you know, because you gave some reasoning of why you thought that would be. And each time you said your reasoning, my mind went somewhere totally different. I'm thinking, of course they're accessing the ER, they're working all week. Of course they're using their phone to do it because they're working and they're able to use their phone while they're working to access their doctor's appointment. everything made perfect sense to me of why they were answering the way they were answering. And so then when your why to your solution is to go out to that migrant camp and to give them data centers and those kinds of solutions, it concerns me that you don't have the actual reasons to why they answered the way they did. And that goes back to that mapping that was talked about earlier. I guess that's just a concern.
To be clear, the end user survey is completely separate from GCM. Those who participated in that did not participate in the GCM. The GCM was focused on organizations. Yeah, and yeah, so yes. Just
Okay, thank you.
I also want to add that the suggestions that were generated from GCM are not they're not necessarily our recommendations. These were suggestions from folks in North Central Washington that, we just compiled and put in the basket of ideas.
I'm sorry, it's just been a really big concern, especially in Grant County, that our BIPOC population is not being represented as well as it should be, because we're not seeing it like at our FISPERT meetings and different, and like the survey, we have a lot more Hispanic than we do Caucasian. Where are they accounted for? Because that survey does not negate that, and it's just a concern. So thank you.
Absolutely.
Right. No, yeah, that's a very valid concern. And so we tried to also speak with organizations who primarily served those populations to also try to capture that, because there's always limitations with an online survey as well, especially for accessing those populations.
Well, this is Nancy Spurgeon, and I would add to that just a very small example too, in that I'm teaching courses at the college through what's called an IBEST model. And so all of the students in this class are Spanish speaking, learning the content through ELL, right? And when we first had to go online, everyone wanted to use their phone because they knew how.
Right.
They didn't know how to use the keyboard, right? But they knew how to use their phone. So I think there's all of those pieces to take into that. So thank you, Penny, for bringing that up.
John?
Right. There was a note in the chat box that said the GCM participants did not see any of the survey results. No, they were completely, in fact, I think they were happening concurrently.
Yeah, and I think my comment, maybe even going with Penny's, is sometimes like maybe, thinking of it again, it would have almost been nice for them to see it when they did the GCM, because you can see kind of sometimes at the community leader and community organization level wise, how that doesn't always link up to what the respondents or the participants are saying. Because I see kind of like, Penny, I do agree with you. When I was seeing the respondents, the kiosks didn't really come to as much of as an importance, but like a lot of the conversations we've had over the last few months, it seemed like it was important. So it's interesting to see that almost, I don't know the best way to say it, but disconnection between sometimes us who are looking at providing the service and the direct respondents.
Penny, do you have another question, or did you just not lower your hand?
Oh, sorry.
That's fine. I just want to make sure. And to be clear, when I say something's interesting in the survey results, I'm just pointing out issues of things to think through and how it might impact how you respond, versus not saying it's significant or anything else, just pointing out some issues to think through on what might limit the responses that we get. But I'm going to continue on, because one thing that we did also look at is secondary data. And I wanted to point that out because even though video is a preference, there's large portions of the region that cannot support that at this time. Looking at the data, many residents don't have a broadband internet subscription at all. So that limits strategies that would reach or target those locations. But this access varies highly by location. And about the finest we can get it from a census level perspective is a zip code, to kind of look at variations across zip code. Some, although the percentage is small, it's important to point out that some don't have access to any computer or even a cell phone. And we should also point out that cell phone data plans really greatly vary by the region too, and the methods that they could support. Obviously, you know, a subset of the population are non-English speakers, a pretty high subset in many, many areas. And lack of insurance might be an issue for some residents in terms of accessing this care. We wanted to provide a little bit of the mapping. We use policy map and kind of map the census data just to show what this looks like. There are some zip codes that over 50% of households do not have access to broadband. That's extremely high. Okanagan seemed to have higher percentages, actually not seemed, they did have higher percentages of the population who did not have access to any form of broadband. But access is very variable. It also varies by income and race. So we know that the Spanish-speaking population also are less likely to have broadband internet. They're less likely to have access to the equipment necessary for those services. And just reinforces findings from other methods that broadband internet access is an issue, which you already clearly know, but seeing it geographically might be helpful. The other issue is even where we have internet access, speed and reliability is very low for a lot of the region. We use the results from the Washington State broadband map. Now, obviously they can't map everybody. It's dependent on you logging in and doing the task, but this still tells us a lot about what internet services there are. If you look up FCC, looks like the region has a lot of access to broadband because of the way FCC defines that. I wanted to do a map with an overlay, but it came out really murky. So it didn't really quite work. But when we look at these speeds, the local data suggests that for many, many areas, this will definitely not support video to video internet, which was the preference in the survey. There's a lot of low speeds. There's a lot of reds and medium speeds. The faces are all blocking so I can see, but like if you, we did an interview with one public utility district, and when we talked about video to video services, they said you would at least need this range in the middle here, or sorry, in medium category. They estimated 50, right? And so if you think about that, estimating 50 for video to video telephone telehealth strategies, many in the region do not have speeds that would support that type of strategy. So it becomes, you know, broadband access is significant. Even those who have access, there's a lot of really low speeds. Again, this is geographically, this varies as well. There are some greens here and yellow, but for some of these strategies, if they don't have green, it's not going to be very supportive of the strategies. So broadband access obviously varies by household income, so we kind of looked into that a little bit. There's a high proportion of the population, you know, that doesn't have access again, and this just varies by income as we would suspect. Based on this, I'm going to go over some of the recommendations that we have. These are only potential tentative recommendations based on the data that we are seeing. We will rely on your knowledge of the area to help craft further recommendations. This is based only on the community data so far. So key findings, obviously broadband access and reliability is a key issue, and speed is a real big issue for this region. It's identified as a big issue across all regions. Christina, what's up?
Oh, I just wanted to let you know that Wendy had put in the chat that we're almost out of time. So I'm wondering if you might want to just skip ahead to the overall recommendations. Okay,
let me do that. So recommendations, you're probably already doing this, but participating in coordinated efforts for broadband access is very much needed. Might participate with the local broadband action teams, connect with the state broadband office. Having a project where you've already looked into telehealth access and maybe using that to garner more grant funds could make your grant application very enticing in that area. We're going to focus on some of the recommendations that we have. We have to get over this high level of distrust in telehealth care technology, and we have to make the public aware of it. So some sort of coordinated education campaign that deals with knowledge of whatever strategies are pursued, but also builds trust in the system itself is going to be essential. And there were community organizations that we interviewed that said they were interested in helping with that process if they could, especially for the population that they serve. So video is most preferred, but based on this, other strategies are going to have to be used. Health stations, especially because of the lack of access to broadband in the region, are probably going to be necessary. They are going to be necessary if this is done quickly. Potentially partnering with local schools and libraries might be a way to do this, an environment that's considered pretty safe and trusted and already has access to high-speed internet. Other states have used a school-based model. You could start local and build up pretty successfully, probably scale up, but the libraries might have resources in this as well. Something to think about. I'm gonna go ahead and skip ahead to, overall, obviously telehealth is, distrust of telehealth is a barrier to uptake, partnering with local organizations to reach diverse communities, having trusted trust messengers to help build support and trust for the systems in place. Some potential first steps to building telehealth care, or doing a telehealth care build out more so than it's already been done, is maybe focusing on the specialty services that are needed. And educating on those, such as providing, doing this for mental and behavioral health, and building a system for that, using some sort of kiosk or station model in those areas that don't have access to broadband might be a way to go and build trust in the system while other elements are being built out. Again, partnering with agencies to help with this. Pastero Brewster has a community resource center that is doing this model. It could be used as a model to help do this in the future. They rent out space to providers in order to provide mental and emotional, or behavioral and emotional health care, meet those needs. And they gave us some information on the costs and stuff that they've needed to do this. To make it successful, though, they've had to reach out and broaden their horizons a bit so they could support it. So they're now providing services for the Okanagan courts and other services to make sure that they continue in the future. But given the region, given what we're seeing, some sort of station is going to be needed to reach most of the population. And especially for some populations, the high amount of distrust, Pasteros Brewster has spent a long time building trust, especially with the Hispanic community, in order to get them to use those services. So some sort of prolonged way of doing that is going to be necessary. And that was quicker than I intended, sorry. So questions and discussion. And again, these are just potential based on the community data. So your expertise in the region and in this area is going to be beneficial and super important as we go out. And whether a pilot test building out for a specialty type care like mental health is the route to go, or some other model. Some of the essential things coming out of this, though, is the distrust in these sort of systems and how we combat that. Go ahead, Penny.
Do we have any change on what the payout is? Because I know that one of the issues to getting the PCPs to participate is what their payback has been, since it is smaller than an actual visit. And I just don't think that's right. I am getting more out of my telehealth visits than I do in person, because it is hard to get in, especially for somebody that has critical illness like myself. So what's going on as far as payment for service? Do you know?
And there's a lot, there are some things going on that would be out of our control, but and we can talk a little bit more because that's a little bit outside of this part. But I get where you're going, and it is definitely connected. I will just ask the board members that right now, do you have any comments or feedback based on what you saw today? I'll be working with both WSU and Ingenium to bring something to you next month. So if there is something that you heard today versus what you heard last, or compared to what you heard last week, and you're interested seeing more next month. We have only 2 minutes. You can speak up now, or I would open up that you can send me information or send me an email, and we can either talk or you can send it in an email.
I also wanted to remind everyone that in the chat are links to all of the items that we have been talking about today. So before we do get off, I encourage you to jump on there and download anything or click on anything that you want to research further. And I do want to thank Christina, Janessa, and Susan for your work today, and Wendy. I will go ahead and we have a comment in the chat.
Yeah, Molly, as you're reading the chat, as Wendy said, this is kind of like a part two of a 3-part series. So next meeting is when we go look and bring together the discussions of engineering and WSU and really look ourselves how the two come together to really identify some key potential solutions moving forward.
And this was a great presentation. So you want to sit down and look at the mapping and really get your thoughts together. And then next month we'll address it again. But at this time, I will be adjourning the meeting and thank everyone for their participation. It was a great meeting and a lot of information, and looking forward to next month. We do have some events coming up as well. So I'll be talking to you all soon. Thank you.
Thank you all.